Hello everyone, this is Chadi Alraies from CVI 2022 in Denver, Colorado. I'm really privileged today to be with Dr. Ethan Korngold. He's from Providence Heart Institute. Ethan, thanks for being with us.
Thanks for having me.
So CVI, as you know, it's peripheral, coronary, and structural, and you are chairing a session on structural heart disease.
Yes.
And you are also presenting a pulmonic intervention, which is unusual for structural heart. Usually it's congenital space.
Yeah, exactly. It was an unusual case for us, and so I was really happy to be able to present it here.
Awesome, sure. So can you fill us in about the indication, how it ended up in your practice, and why the therapy?
Yeah, absolutely. So this was a case of a man in his 50s who had had extensive X-ray therapy when he was a child, had multiple previous interventions, including an open heart surgery, and had severe pulmonic stenosis due to radiation. He was not a surgical candidate, and so he came to us looking for other options. Multiple admissions to the hospital with heart failure, and so we did a transcatheter pulmonic valve replacement using a SAPIEN 3 valve, off-label, of course.
Yeah.
And it turned out very well.
Yeah. And in terms of evaluation, CT imaging or something, and sizing, is it follow the same protocol for TAVR or has something different process?
There are definitely some things to look out for. Most of the experience in pulmonic valve replacement is from the congenital and adult congenital literature. But in his case, the anatomy was relatively straightforward. There was no risk to the coronaries for compression. It was a very circular annulus that sized well for a SAPIEN 3, and the procedure went very straightforward. It was a lot of planning and a lot of concern and a lot of open discussion with the patient that this was really pushing the boundaries, and he was completely on board. We had support from our excellent heart failure colleagues and our imagers, and everything went great.
Yeah.
I think it really sort of underscores how flexible and creative structural heart interventions can be, and how when the team works together, really any challenge is
In terms of
awesome.
implantation for the pulmonic, and excuse me, I'm not a structural person, but from pulmonic standpoint, is in terms of degree of implantation, and you have an annulus usually in the TAVR. So does this follow the same rules for pulmonic?
Correct, yeah. So the landing site can be an issue with pulmonic cases, and in some cases a pre-stent strategy is needed. So there can be a self-expanding pre-stent or even sometimes a pulmos stent to create a landing zone for the transcatheter valve. In his case, he had a very calcified circular annulus of the pulmonic valve with pulmonic stenosis, so a straightforward SAPIEN without a pre-stent was employed, and it worked well.
Perfect. The pulmonic valvuloplasty performed, or was straight deployed?
We did it predominantly, frankly, for sizing, but also just to make sure that we didn't run into any issues.
And do you require the same thing, rapid pacing? In this
we did do rapid pacing in this case.
Although it's a slower flow from that system.
Definitely slower flow. And for tricuspid interventions, it's not always necessary, but we just wanted to make sure that we weren't going to take any chances with this one.
That's an important aspect. And this is through a venous. How about navigating the sheath through that? What technique?
It's a little bit sort of tricky. And so we put a Meyer wire in the pulmonary artery, which is really a very stiff wire with a soft, floppy tip. That was able to provide enough of a rail for us to track with it.
Awesome. And the closure, what's your closure for big vein? Usually?
For big vein, I typically just do a figure-of-8 skin suture, which maybe is a little bit old-fashioned, but it seems to work, and it's inexpensive, and we take it out the next morning, and that's that. So, yeah.
In terms of antiplatelet or anticoagulation for these valves, is it different?
He had another reason to be anticoagulated, so it's not an issue we had to bridge.
So you continue on that.
Yeah.
Well, that's interesting.
Yeah.
So tell us about your experience with CVI so far.
It's great. I mean, I've been coming to this conference for years. It's just so practical. I always learn sort of new tips, either from structural or peripheral or coronary. It's great people, and I really enjoy being a part of it. It's fantastic.
Well, thank you so much for being here, and thanks for the presentation. Watch these videos and others on CVI YouTube channel. This is Chadi Alraies. Ethan, thanks again for being here.
Thanks. Nice talking with you.